So our question for the rectal cancer debate is, should the strategy going forward to try to improve patients' outcomes with rectal cancer be one of using 3D conformal-based radiation therapy with an increased emphasis on radioprotectors, or should an emphasis be on advanced technologies, including IMRT, to reduce dose rates and toxicities? And to argue the side of 3D conformal radiation with radioprotectors is Dr. Bill Regine. Dr. Regine, Bachelor of Science degree from SUNY Albany in chemistry, MD from SUNY Syracuse, and did his residency at my alma mater, Thomas Jefferson. He is now the Schneider-Foxman Chair of Radiation Oncology at University of Maryland and Executive Director of the Maryland Proton Treatment Center. He's been the leader of numerous cooperative group trials, important in GI cancers, and throughout his tenure being a leader of RTOG. He also leads the normal tissue toxicity program at the University of Maryland. Thanks for coming, Dr. Regine.
All right, well, thanks for having me. I guess because I'm older, they asked me to do the 3D side. And actually, what I'll show you is actually what I do. So this was kind of easy. I'm glad I got this side. I have no disclosure, so what I hope you'll gain at the end of this is not only understanding what are the OARs that are at issue when we do a neoadjuvant RT, but in an era where I think we're increasingly becoming aware of the patient perspective, share with you some data and literature about what matters to patients, because it can't just matter to us in terms of what they're worried about in toxicity. We'll go over the prospective clinical trial data. I think it's important, obviously, in this kind of debate. And then, particularly because of our own lab experience, I'll review where we're at with the status of radioprotectors and the use of rectal cancer. So let's go back to radiotherapy 101, right? What's the goal of treatment? We want to get rid of tumor or tumor cells, and we want to avoid damaging surrounding healthy tissue that are near or adjacent to the PTV, but we're trying to treat the PTV. So let's start with literature from the Swedish group, where I'm going to show you what are the late effects of neoadjuvant RT and give you the worst case scenarios, because in Sweden, they use hypofractionation. So large fraction size is 5 gray times 5. So the most frequently seen adverse event is bowel dysfunction. Radiation patients have more problems with anal incontinence, urgency, frequency, or evacuation. And if you read the paper and talk about what are the potential etiologies, for small bowel and large bowel, it's probably related to mucosal inflammation and decreased absorption, and radiation that results in stiffening of the surrounding perirectal fat or soft tissue. And for those of us who treat breast cancer, as I tell my residents, you can imagine what's happening in the body by the patients you treat externally. So you see breast cancer patients, they get a tuck. After radiation, things become a little firmer. So imagine that happening in the perirectal space. And I think that explains some of the toxicity we see. Damage to the sphincter muscle, documented decreasing of resting pressures, and also potential damage to the nerve plexus that invades about the perirectal tissue. And this has all been confirmed by manometry and ultrasound in the Stockholm studies, where patients have lower resting and squeeze pressures, as well as increased scarring of the anal sphincter. So let's start defining the OARs that we're going to be debating, Brian, right? So potentially small bowel, large bowel, sphincter muscles, and anal sphincter. So everybody, here's an experience from the Dutch, who also use large fractions, where it's established that using 5 times 5 in the setting of TME, this is modern surgery, is associated with reduction in local regional recurrence. Again, hypofractionation, this should be the worst results we would see in terms of late effects from neoadjuvant RT. And here's their report of what they saw. First of all, no significant difference in voiding or stoma function compared to unirradiated patients. No increased rates of small bowel obstruction, urinary issues, femoral neck or pelvic fractures in patients who've gotten radiation. Again, what you see, just like Stockholm, the issue is related to bowel function for the RT patients, and this bowel function is described as increased bowel frequency, incontinence, urgency, and emptying difficulties. right? And interestingly, as per protocol, the CTV excluded the anal sphincter for upper lesions or lesions that involved an anterior resection. That was 75% of the patients. So the majority of these patients did not have the anal sphincter involved, and still you saw these emptying and urgency difficulties. So anal sphincter might not be a key component of late effect. And so despite sparing that, you could see that the compliance of the tissue around the rectal remnant is probably important with regards to the fecal incontinence that these patients experience as a late effect. So I would describe that a major OAR is the surrounding perirectal tissue. So how about patient perspective? So here's a nice publication from a year ago, which tried to get a sense of what not only the radiation, what makes the difference for the radiation oncologists in terms of their concerns of injury, but what do the patients worry about? And this was conducted in 31 previously rated rectal cancer patients, and they were given a rather lengthy survey, and they had to have 80% agreement between both the patients and the radiation oncologist as to which benefits or harms preoperative radiation should address. So in terms of the harms for the patients, all of them wanted to avoid altered defecation pattern or fecal incontinence and obviously any wound healing problems. For men, they wanted to avoid erectile dysfunction, ejaculation issue, infertility. For women, vaginal dryness, painful intercourse, menopause, and infertility. So that's what matters to patients, okay? So I would describe that the OARs that matters to patients and most significant to them are intrinsic to the low pelvis and surrounding perirectal tissue. This is a slide of a patient that actually finished treating about a month ago. So what's on this slide in yellow is the PTV, and I left the 50% isodose just to give you a sense of what the field edges would be. So now let's look at what the OARs that are really at issue in terms of deciding 3D versus IMRT based not only on the literature, but what's most significant to patients. Okay, so distal large bowel, nerve plexus, perirectal tissue, sphincter, which in this patient was generally out of the field. It's not the femoral head or neck. It's not the bladder. It's not even the small bowel. Right? So all of the OARs that patients worry about and that seem to be issues documented in the literature, at least for late effects, is in the PTV, what we're trying to treat. Okay? So again, the goals. We're trying to eradicate tumor cells and protect things that are outside the PTV. So now let's look at prospective evaluation of 3D versus IMRT. So this is the one prospective study, and maybe Brian's got something new he's going to pull out of his pocket. But RTOG 0822 is a study that was actually conducted by one of my faculty at University of Maryland. It's the first phase 2 multi-institutional study that compared IMRT versus 3D. All patients got 45 gray in 25 fractions with IMRT, and then a 3D boost to 5.4 gray. The chemotherapy was capecitabine and oxaliplatin, and they did this study, and the goal was to compare it to the previous RTOG phase 2 study, 0247, which used the same chemotherapy, same eligibility criteria, and the endpoint was to see a 12% reduction in combined grade 2 or greater GI acute toxicity. And I would describe that's a pretty low bar to hit. Okay? All patients, before they started their radiations, had to have their imaging submitted and underwent central QA. And I know because my junior faculty kept asking for more time to review these. So these were coming in. This is almost 70 patients. And the constraints were primarily aimed at reducing volume small bowel exposure, which again seems logical because that's the organ at risk that should be beyond the PTV you're trying to spare. And these are pretty tight. I don't know how, maybe we can get a poll of how many people use these type of constraints, but V35 less than 180 cc, V40 less than 100 cc, and V45 less than 65. So very tight constraints. You can't criticize the study for that. If hopefully you do use, this is the anal-rectal atlas in the RTOG website, which was the guide for how people set up their volumes. And the primary endpoint was not met. So if you look at 0822, which is the study. It was a 51% of grade 2 or greater GI toxicity versus 57%. Was not statistically significant. All but 3 of the patients had unacceptable variation. So less than 5% of patients did not meet the OAR dosimetric constraints that were set. So despite tight constraints, no significant difference. And this publication has finally been accepted at the Red Journal. It will be coming out hopefully the next year. So in terms of this study, right, this was the first multi-institutional prospective study that evaluated IMRT versus 3D. It showed that you can do it, especially utilizing standardized Atlas. It did not result in a statistically significant reduction in acute, grade 2 or greater toxicity, and IMRT in rectal cancer remains to be more clearly defined. That's the conclusion of the paper. So when might IMRT be helpful in the treatment of pelvic or GI rectal cancer? And I could think whenever there's an issue or chance to, or situation where you have to treat the inguinal nodes, you're probably going to see a benefit. And this was demonstrated by 0529, Lisa Kashnik's study. It was published a couple of years ago. This was anal cancer patients. And I want to note, this had the same fundamental design as 0822 rectal cancer. It was comparing, hoping for a reduction in toxicity compared to the predecessor RTOG study. In this case, for anal cancer, it was 9811, and they wanted to see a reduction in GI or GU toxicity, and they had planned secondary endpoints reduction. And in terms of acute toxicity reduction, and I assume this is standard for most people in the audience, there were significant reductions in grade 2 or higher heme toxicity, as well as GI, GU, dermatologic, and GI. Again, this was seen for anal cancer, not seen for rectal cancer. Same basic protocol design. So when my IMRT be helpful in rectal cancer, and this is when I use it typically, is when the inguinal nodes may require treatment. So if somebody has invasion of the anal canal or sphincter or lower vagina, we typically use IMRT. So what about radioprotectors? And having just given the boards in Louisville, this is still the answer we're looking for. For simulation, people should be getting small bowel contrast. A belly board is something you should try to get your patient on. Bladder distension for bowel displacement is an easy way to mechanically radioprotect an organ that's at significant risk. And CBCT for QA of bladder filling. This is the patient I treated, and this is a great example. And this is typical of most of my patients. My therapists consider it a challenge, and they'll tell our patients to get off the table if they haven't gotten their bladder to the level it should be. We usually do CBCT for the first 3 days of treatment to make sure they're going to reproduce, and then we'll do once weekly CBCT, and the rest of the time it's daily KV to reduce the PTV. But you can see the small bowel is easily out of the field thanks to the distension this patient is achieving. This is pretty typical. So what about other mitigation of radiation toxicity? Where are we? So cancer survivor population, by 2022, there'll be 18 million survivors. This is a 31% increase since 2012. And the largest growth will be in individuals living more than 15 years. The burden for our society in terms of cancer survivorship is about $5,000 a year related to toxicity management, 80% having acute toxicity, and 1.5 to 2 million survivors will have chronic radiation-induced GI dysfunction. 15% of that will be grade 3 or 4. And right now, there are no FDA-approved therapeutics to prevent or treat GI toxicity. There have been some promising data in phase 1-2 trials, but nothing that has panned out in phase 3 trials. So right now, we're still continue to use analgesics, antiemetics, and antibiotics for GI toxicity. But the good news, U.S. government's making a big investment in mitigators of radiation exposure, and that's in the context of dirty bombs. So there's about over $1 billion investment by our government to develop things that will hopefully help improve survival of dirty bomb exposure, people exposed to total body radiation. The other priority that was established in the last 5 years is that while we want people to develop these kind of compounds that ideally will keep on the shelf, there needs to be dual utility. The same kind of drugs have to be able to be used in cancer patients who are being exposed to radiation. So they must also have an associated clinical benefit. There are a lot of companies out there who are trying to develop products to mitigate against radiation injury, and there are some that are currently in or will soon be in phase 1 or 2 clinical trials. And this is just a reminder, in the top part, this is normal wound healing with a balance of proliferation and remodeling, whereas for radiation-induced injury in the lower part of the slide, there is actually imbalance, and you get excess collagen formation and deposition and scarring, which causes late radiation effect. Lots of drugs and companies out there trying to attack various parts of this cascade to make a difference. And because of this, about 3 years ago, we established, we went from a radiobiology lab to a translational radiation science lab we now have, and with the focus on not only improving tumor response, but minimizing radiation complications. In this context, we recruited Željko Vojvović, who Brian knows well, comes from Duke. He's got about $150 million in research and development grants from private and public and partnerships, as well as federal funding, with the goal of eventually, hopefully, developing drugs. And now we have some drugs we're going to be pushing into the clinics that can minimize against toxicity. One that's coming up is in non-small cell lung cancer. And we actually just announced last month the first drug that's been FDA approved for use in whole body exposure, Neupogen. We have a murine and a non-human primate model in which we look at all different types of radiation toxicity. And just to give you a sense, there is a lot of money by companies being put in to look at GI-related toxicity. So it's $35 million by one company, another $30 million from another company, and the list just goes on and on. So I think given the investment, we will see some benefit from radioprotectors in the future. In the meantime, late effects associated with neoadjuvant radiation for rectal cancer, which are most meaningful to patients, are intrinsic to the low pelvis or surrounding pararectal tissue. They're in the PTV, folks. Okay? Prospective multi-institution comparative evaluation shows no significant benefit in terms of reduction of acute toxicity by IMRT. And while use of mechanical radioprotectors are helpful and should be used and attempted to be used in all patients, in terms of chemical radioprotectors, lots of dollars being invested. I think there's a significant hope for the future. In the meantime, 3D remains the standard of care in patients with neoadjuvant RT for rectal cancer, and the use of IMRT should only be considered in exceptional circumstances. Thank you.
Thank you very much, Dr. Regine. That was excellent. And now to present the counterpoint, Dr. Brian Czito did his medical training at the Medical College of Georgia, his residency at Massachusetts General Hospital, and now serves as the Proctor Associate Professor of Radiation Oncology at Duke University. He's been a leader in clarifying the landscape in rectal cancer as far as short course versus long course chemoradiation, and has written extensively on the emerging role of intensity modulated radiation therapy and proton therapy in treating anorectal cancers. So welcome to the podium, Dr. Czito.
All right. I'd like to thank the organizers for inviting me. My only disclosure is that I don't necessarily believe everything I'm going to say today, so keep that in mind. First question is, why would you think about using IMRT in rectal cancer? When you break it down, there are three primary reasons, and two of them are related. First is to reduce acute and late toxicities, which I'll argue are still a big problem in the treatment of rectal cancer, particularly with the integration of newer systemic agents, which I think we're going to see in upcoming years. Second, along that line, is to avoid breaks in treatment. And finally, dose escalation. And I'll get into that in just a little bit as to why that you may be seeing that more on the scene in upcoming years. I think everybody in the room knows about the German rectal cancer trial, basically a landmark trial that establishes how we treat these patients now. Simple randomization to preoperative versus postoperative chemoradiation therapy. I think we all know the results of this trial as well, which showed that just by simply changing the sequence of treatments that you can reduce local failure rates by over 50% in these patients. And when you look at why that is, it's one of the reasons and one of the thought processes behind it is because you get much better compliance with pre-op versus post-operative chemoradiation therapy secondary to toxicity issues. And in fact, when you look at the compliance rates from this chart here, the ultimate compliance rates in the preoperative arm with chemoradiation therapy, it's about 90%. And when you look at the post-operative arm, it's about 50 to 60%. So that may account for a large reason why we're seeing these differences with pre versus post-operative treatments. But even with preoperative treatment, what you can see on this table is that acute toxicities, grade 3-4 toxicities, which are serious toxicities in these patients, still occur in about a quarter of patients. And when you kind of get more granular in these patients, what you can see is that high-grade toxicities, and grade 3 and 4, again, these are serious toxicities in these patients, comprise about 12% of patients treated in this trial, and late toxicities made up in the GI realm about 13% of patients. And when you look at other contemporary randomized trials looking at preoperative chemoradiation, what you can see is you see similar rates of acute grade 3+ toxicities in both EORTC trial that was reported about 7 years ago, as well as the FFCD or the French trial, again comparing preoperative radiation plus or minus chemotherapy. What you're seeing is about 15% of high-grade toxicities in these patients. But when you look more critically at the data, what you see is that the grade 2+ toxicities are even higher. And remember, grade 2 toxicities are not trivial in these patients. Grade 2 toxicity means that you can have up to 6 additional bowel movements above and beyond diarrhea, what you would have above and beyond your normal. You require hydration, less than 24 hours. So again, these are not trivial and can potentially impact patients' treatment and quality of life. Another interesting aspect is when you look at secondary analyses on the German trial, what they found was that prolongation of radiation is associated with poor local regional control. And basically what that means is that acute toxicity and the treatment breaks associated with it can impact disease-related outcomes. So we really, when you look at the bottom 3 or the bottom 2 circles, we've really moved beyond these trials since that time. And really one of the primary focus with it, some of the primary focus of ongoing trials and now completed trials have been the integration of newer agents with radiation therapy in the preoperative treatment of rectal cancer. An example of this is oxaliplatin. I've got some other agents listed here: irinotecan, EGFR inhibitors, anti-VEGF inhibitors, even PARP inhibitors more recently. And really one of the underlying goals at integrating these drugs with radiation therapy in the preoperative treatment of rectal cancer is to come up with more robust or more active agents that can potentially improve rates of downstaging as well as pathologic complete response. But what we also know is not only are these tumor sensitizers, but they're also normal tissue sensitizers. And when you look as an example, a CLGB trial that led to a randomized trial, or led to several randomized trials looking at the integration of oxaliplatin in this setting, we go from acute grade 3-4 toxicities rates from about 15% up to about 37, even 40%. And this is largely borne out in the randomized trials that have been completed looking at the integration of oxaliplatin with preoperative 5-FU-based chemoradiation in the treatment of rectal cancers. And at the end of the day, there have been 5 randomized trials similar to these, and essentially all of them have shown that there's no benefit of the use of oxaliplatin, but adding this agent clearly enhances the toxicity of these treatments. So again, the toxicity is an important endpoint. When you look at where does this toxicity come from in these patients, I would agree with Dr. Regine that some of the toxicity comes from what's inside the PTV, but there's also a significant component that comes from outside the PTV, namely small bowel. And when you look at this now, what is considered a somewhat classic article in 40 rectal cancer patients, or analyzing 40 rectal cancer patients treated with 5-FU and radiation using fairly standard bowel sparing techniques, prone, belly board, full bladder, and they looked at the correlation between dose of radiation received in terms of volume of bowel receiving it. What they found is that doses matter to the small bowel, and what they also found that even at low doses, for example, of V15, that it makes a difference in terms of acute toxicities. And you can see on the left hand and the right hand columns, what you can see if you had a small amount of small bowel receiving 15 gray, less than 150 cc's, you had virtually no high grade toxicities. But as the volumes increased, you had a corresponding increase in small bowel toxicity. So the question is, can IMRT do better in this? Well, I think if you look at dosimetric studies, the answer to that is yes, it can. And there are many of these that are out there. I picked one because I didn't want to put everybody to sleep. Basically, what it shows, this trial from MD Anderson analyzing 10 patients shows that IMRT can significantly decrease mean bowel dose, V40 on the bladder, the pelvic bones, the femoral heads, as well as overall small bowel dose at V15. And their conclusion, and really it's almost universal conclusions of all these dosimetric studies, are that we can do better with IMRT versus 3D. We can get as good of, if not better, coverage, and we can decrease dose to organs at risk. Now, analyzing another study that Dr. Regine has already talked about, looking at a similar disease, not quite the same and not quite the same target volume, but similar anatomy in the body, the RTOG 0529 study in anal cancer, again, prospective phase 2 trial with the primary endpoint of decreasing grade 2 plus toxicity, GI-GU, compared to an older RTOG study. Also looking at other adverse events, feasibility, can this be done in a multi-institutional setting, and also disease-related outcomes. And if you look at the column to the right, or the graph to the right, what you can see is this is a negative study. Okay, the primary endpoint was looking at grade 2 plus GI and GU toxicities. And when you look at that bar graph of grade 2 plus GI and GU toxicities, there's no difference. So if you look at the primary endpoint, this overall was a negative study. Okay, however, when you look more critically at the data, what you can see in the next bar graph over, when you look at higher grade toxicities, primarily grade 3 plus GI and GU toxicities, there's a significant reduction with the use of IMRT. And in fact, when you look at GI toxicities specifically, 3 plus, what you can see is there's about a 15 percentage point reduction with the use of IMRT in this study as compared to the RTOG 9811 study. So what's the experience in rectal cancer IMRT? Well, you've heard about one prospective study, which I'll come to in a minute, from the RTOG looking at rectal cancer, but there are others, or larger institutional experiences using IMRT versus 3D. I'd like to review several of those briefly. The first is a multi-institutional study from largely academic centers looking at a series of 86 patients treated either with 3D or IMRT, and the conclusions were that IMRT decreases hospitalizations and ER visits, no breaks in the IMRT group versus the 3D group. Grade 3 toxicities overall were significantly decreased, and diarrhea, although numerically superior in the IMRT group, was not statistically reduced. Their conclusions were IMRT decreases treatment breaks, emergency room visits, hospitalizations, and all other grade 3 toxicities. But this isn't an isolated paper. There's another one from BU. Again, all these are recent studies looking similar design, looking at their collective rectal experience of IMRT versus 3D. And what they found is the IMRT group had improved rates of grade 2 plus diarrhea, grade 2 plus GI toxicity, lesser amounts of treatment breaks, and their overall treatment duration was less versus the 3D experience. And again, similar to the prior study, what they concluded is it results in better acute GI toxicity and improved pathologic downstaging profiles, and prospective evaluation is warranted. Another larger experience out of the Mayo Clinic, Arizona, again, similarly compared IMRT versus 3D in their experience, very similar outcomes. Grade 2 diarrhea and grade 2 GI toxicity both improved with the use of IMRT versus 3D techniques. And again, that was similarly their conclusions. Finally, another larger experience from Memorial Sloan Kettering, Same design, looking at their rectal cancer experience. IMRT significantly improved rates of grade 2 diarrhea, and they noted that all 3D patients had higher rates of grade 2 plus diarrhea. And again, their conclusions were similar to the other institutions I've given you already, in that IMRT resulted in less toxicity and fewer breaks in these patients. Now, circling back to the RTOG 0822 trial, again, you've heard about the design of this trial already. Again, things to point out, 2 drugs were used, so it's an oxaliplatin-based regimen, which we know increases toxicity in these patients. Radiation was given 45 gray IMRT with a 3D boost, 5.4 gray. Patients went on to surgery and outback chemotherapy. Again, as you've heard, the primary endpoint is similar to the anal study from RTOG. Can IMRT reduce grade 2 plus GI toxicity versus a historical arm? I won't go over the constraints again. Looking at the results of this trial, and this is yet unpublished, 68 evaluable patients, 58 patients had target drawn per protocol. So I would point out this is significantly different than the anal cancer experience, where 80% of patients required some kind of modification of their field with IMRT. This shows that most treating physicians are getting the target volume correct with these patients. But surprisingly, what they found is there is a 52% grade 2 plus GI toxicity rate, clearly exceeding their target rate of 28%, and yet arguably higher than what was seen in RTOG 0247. The rate of grade 3 plus diarrhea, again, nearly 20% in patients, similar disease-related outcomes. And interestingly, they could not find any correlation of GI toxicity with small bowel DVH parameters. And their conclusions were that IMRT did not reduce the rate of GI toxicity, which was largely in contrast to what we're seeing from other reports that are coming out. So the question is, why is that? Well, it's possible IMRT is no benefit in these patients. It's possible that we're really not selecting out the patients that are appropriate, or better selecting the patients that might be appropriate for IMRT. It could be that the constraints that we're using are not the right constraints. There's some question about how do we best contour small bowel when we're looking at these small bowel DVHs. Should we contour the small bowel itself? Should we contour the entire peritoneal space? There's also a question that physician grading of these side effects may be imperfect, and in fact, it might be better to rely on patients to grade their own toxicities versus the physicians. Other caveats to this trial are that patients were not necessarily treated with maximal bowel sparing. They didn't have to be treated prone or bladder full. They didn't have to use a belly board. Again, there was a 3D boost to the mesorectum. So I think one of the conclusions that I think you'll see from this paper are that it's important to identify appropriate dosimetric constraints, which I still don't think we have a good handle on in terms of small bowel. It's important to use patient-related outcomes and not what physicians are describing, and really to be more selective about the patients who might be appropriate for IMRT. And this is not going to be the final end to this question. There's an ongoing trial in Ireland right now that's looking at this exact question. Preoperative chemotherapy and radiation in rectal cancer, IMRT versus 3D, but the results of this, I think, are going to be a ways off. Also, what wasn't focused on before is late toxicities in these patients, which is an important endpoint. So patients may want one thing or have things that are important to them, but what you have to remember is many of these patients are going to be cured, and what they don't anticipate is what's going to happen down the line in this fairly curable group of patients. What's going to happen at 10 and 15 years after they've been cured of these? What we also know is that there are multiple reports that suggest that acute GI toxicity is an independent and significant predictor of late toxicity. So if you have acute toxicity, it may predict for what's going to come 10, 15 years down the line. Late toxicity profiles are relatively ill-defined in the world of rectal cancer. One study that did do a reasonable job at doing this is the Trans-Tasman or Australian short versus long course radiation trial in rectal cancer. Again, a simple trial, European style 5x5 with surgery 1 week following radiation versus conventional US style 50.4 gray with concurrent continuous 5FU. What they found, no difference in local control between either arm. And interestingly, what they found was that there was no significant difference in long-term toxicity between these groups. But what you have to remember is the follow-up in this trial was only a median of about 5 years, which seems like a long time, but in the world of rectal cancer, it's really not. And when you look at where most of the toxicities were in this trial, they were primarily GI related. Okay? When you look at other series, such as the Dutch TME series and the Swedish rectal cancer trial, which I think everybody is familiar with, what they have found is that with radiation therapy, there are higher rates of perineal infection, small bowel obstruction, hospital readmission, incontinence, bleeding, discharge and pad use, and sexual dysfunction. And what we don't have is we don't have a really good handle on the short versus long course profiles between these two. I would argue that this is something that matters to patients. And when you look at the long-term follow-up of the Swedish rectal cancer trial, and you look at small bowel obstruction, you can see at the upper curve is small bowel obstructions requiring surgery, and the lower is that not requiring surgery. And what you can see at a median follow-up of greater than 14 years, that these treatments are the gift that keeps on giving, meaning that there's no tail to that curve, and that incidence keeps on going out as you get on to 10, 11 years. So this is a significant or a potentially significant problem in these patients. Similarly, when you look at the Dutch TME trial, and along Dr. Regine's point, many of these come from what's in the PTV, but still these long-term toxicities are a problem. When you look at rates of incontinence during the day or at night, anal mucus discharge or blood loss and the use of pads are all significantly higher with radiation therapy. I would argue there's also one more thing that patients care about. They just don't realize it yet, and that's pelvic fractures in these patients, which could potentially be improved with IMRT. And when you look at this study by Nancy Baxter, a SEER database analysis looking at pelvic malignancies treated with radiation therapy between 1986 and 1999, some patients received radiation, some didn't. What you can see is the incidence of pelvic fracture rises with time if you got radiation therapy, and it keeps going as time goes on. So clearly this is another significant factor in treating these patients and potentially reducing dose to the hips and to the pelvic bones. So the final portion of my talk, I'd like to talk about dose escalation using IMRT. So you could ask, and similar to one of the questions that came up during the last session, why the heck would you want to do that? The tumor's coming out. Well, there are several reasons I'd like to discuss. One is you could potentially increase pathologic complete response rates, which we know, based on many series, tends to improve outcomes. So the higher the pass CR rate, the more likely you are to achieve long-term survival. Additionally, there may be some role for dose escalation and downstaging of the tumor and potentially increasing sphincter preservation in low-lying tumors. There is some data supporting dose escalation in the world of rectal cancer. When you look at Princess Margaret data, a series of phase 2 trials, what they found is treating between 40, 46, and 50 gray, there was a higher rate of pathologic complete response as dose increased. And clearly, there are now investigators that are using IMRT for dose escalation. This is a recent report from Madrid using IMRT and capecitabine in 74 patients. Patients received 46 gray and 2 gray per fraction to the pelvis with a simultaneous integrated boost, 2.5 gray per fraction to GTV. And what they found is they could achieve high rates of downstaging, high rates of pathologic complete response, and margin negative resections with relatively modest rates of high-grade toxicity in the GI and GU setting. And their conclusion was this is well tolerated and with high rates of pathologic complete response. But I think really where you'll likely see more focus on dose escalation and potential use of IMRT in the upcoming years is through this question, is when is surgery not necessary in these patients? For years, really the only group that was reporting this was out of Brazil and Sao Paulo and Haber-Gamma et al. And as you can see, they had really impressive results in these patients that not everybody believed for a long period of time. So when you look at their initial experience of 360 patients, about 30% or just under 30% had a clinical complete response. They decided to watch them. And what they found was that the local recurrence rates in these clinically complete responding patients were surprisingly low. In fact, they only had 6 local recurrence recurrences cumulatively, and their overall survival and disease-free survival rates in these groups were surprisingly high. They recently updated this last year. Another group of patients, 183, almost half of them, when analyzed at 8 weeks following treatment completion, had a clinical complete response, underwent this watch and wait, again, non-surgical approach. And what they found was that their relapse-free, local control or local relapse-free survival rates, not quite as good as they were before, but what they also found in the patients that failed locally, they could salvage almost all of them. Okay, so their implication in this is that you weren't really losing a lot with this watch and wait philosophy. Other groups have taken this more seriously. If you look at the watch and wait trial from the Netherlands, a small trial published in the JCO several years ago. Again, 21 patients who had a clinical complete response, followed very carefully, radiographically and endoscopically. And out of those 21 patients, they only had one local recurrence. And finally, this experience from Memorial Sloan Kettering, which generated a lot of press after this year's ASCO GI, what these investigators did, and remember when I say investigators, it's interesting because almost all of these are driven by surgeons and not radiation oncologists. So these are surgically driven trials. What they found is that when they treated patients with 45 to 55 gray with 5-FU-based chemotherapy, sometimes with chemotherapy up front, and they achieved a clinical complete response, and then they compared those to patients who had undergone radical resection and achieved a pathologic complete response. So again, the second group, very favorable group of patients. What they found was in the non-operative patients, 26% rate of local failure, similar rates of distant metastases, and the disease-specific and overall survival were very similar between the groups. All regrowth in these patients was able to undergo salvage therapy, usually within a year, and that's when they saw the regrowth within a year, and their rectal preservation rate was 72%. So I think what you're starting to see is you're starting to see some rumblings of a paradigm shift, or at least some efforts towards trying to create a paradigm shift, moving to a non-operative treatment in rectal cancer in select groups of patients. In fact, this has generated a phase 2 multi-center randomized trial. There are other trials that have now come online, 2 in the United Kingdom, another phase 2 randomized in Brazil. And interestingly, last year, a group of European experts in rectal cancer got together and indicated that these clinically complete responding patients should be given watch and wait as an option in patients who do achieve a clinical complete response. So again, I think this is where dose escalation and where IMRT may start coming into play to achieve higher rates of clinical complete response in these patients. So what do the experts say? Well, if you look at what the NCCN guidelines say about IMRT, they say it should only be used in the setting of a clinical trial or in unique clinical situations such as reirradiation. How about the ACR expert panel? They say that it is the consensus of the expert panel authoring this document that IMRT clearly decreases toxicity in the treatment of rectal cancer. Certain situations may be more appropriate, such as postoperative treatment following APR or inguinal lymph node involvement. In fairness, they do say that you should put these patients on a trial if possible, and if not, you should use the contouring atlas. So, in conclusion, GI toxicity, despite contemporary treatment approaches, still is a major obstacle in the treatment of rectal cancer, both acute and late, and can potentially impact on outcomes. Toxicity with the integration of newer agents will almost undoubtedly increase when using agents above and beyond 5-FU. Dosimetric studies, not unexpectedly, show that IMRT gives better results. And the clinical data outside of the RTOG study largely supports decreased toxicity of IMRT with 3D. RTOG 0822, with its caveats, was a negative trial, but there are other trials that are ongoing. And again, I think that in coming years, you will likely hear more about this non-operative treatment approach and potential dose escalation using IMRT, and even the expert panels differ on their approaches or recommendations in terms of IMRT. Thank you.
That was excellent. That was excellent. Thank you very much. While the GU team is coming up, we'll maybe be able to take one question from the audience.
For the patients that do it with the non-operative approach, how are you evaluating them clinically? Are you doing any of that now in your institution?
I'm not. But I will tell you how. Oftentimes it consists of, there are different algorithms people are using, but oftentimes it consists of an endoscopy every 3 months. And the reason for that is most of these local recurrences actually are going to be mucosally based, so they'll be visible. If you look at the Memorial experience, they're scanning the patients about every 6 months as well, and they would get blood work and tumor markers, CEA, as well.